So let's go ahead and talk a little bit about a few upper extremity blocks. And these are the main ones I'm going to go over. There are probably close to 100 different regional anesthetic techniques you can use in different blocks and different planes. We're going to try to hit some of the high yield ones for the emergency department, but there are many more. This is not comprehensive. We could not cover them all into a single coherent discussion. However, once you master the principles, and again, if you're good at guiding a needle, you can review the anatomy and the landmarks in pretty quickly and adapt this to any new blocks or anything new that might emerge. So these are the ones we're going to go over, and just a quick little bit of some quick notes about each of these. So the interscalene block, things you have to worry about are diaphragmatic paralysis on the side that you're doing this. Horner syndrome is a potential complication, and it often leaves out some of the distal part of the hand. So if you're worried about the hand, this is not the way to go. The supra and infraclavicular blocks, these give you a similar region of anesthesia, have similar complications as pneumothorax, diaphragmatic paralysis, and Horner's. The infraclavicular, since you're a little lower, has a little bit lower risk of diaphragmatic involvement in Horner syndrome, but similar anesthetic properties. And then the axillary block gives you a little bit more distal forearm and hand. And depending on whether you include the musculocutaneous nerve or not, you'll get the nearly complete portion of the forearm. This is an important thing with one of the most common blocks you'll do as you kind of start out, and one of the ones that I first learned, or some of the group that I first learned, was these forearm blocks for different things on the hand. You have to remember the distribution of innervation on the hand. So it's maybe not intuitive if you kind of forget median versus radial versus ulnar. So if you're not sure, worth looking up. And the biggest thing that sometimes can throw people off is the transition on the thumb. So depending on where their lesion or whatever's wrong in their hand is, you may need to include median and radial nerve. And then ulnar nerve is pretty clear, but if you're not sure, double check yourself on median and radial and kind of where those distributions might lie. So quickly into the brachial plexus, a few specific complications that just kind of overarching complications of brachial plexus blocks. And pneumothorax, this is higher or lower depending on if they have COPD or not. Phrenic nerve involvement, which is going to paralyze the diaphragm on that side. And then the cervical ganglia, which can lead to Horner syndrome. Again, unlikely and lower likelihood by using ultrasound, but some of these can still happen. This phrenic nerve thing is really not much of a consideration if they're a pretty healthy person, have pretty healthy pulmonary status. But if they've got COPD, then maybe this is not the way to go, because there's a reasonable chance you're going to cause temporary phrenic nerve paralysis. The cervical ganglia thing, it can happen. Mostly it's worth being aware of so that it doesn't scare you and think there's some other worse complication going on. So, and pneumothorax, this is something you can pretty much look for immediately after you're done. So this is an example where we see a rib here, rib over here. This is the pleural line. There's no sliding here. So we can diagnose this quickly after we're done, or kind of rule it out immediately after the procedure. In this case, there is a pneumothorax present. Sometimes with these brachial plexus blocks, you can get phrenic nerve involvement, and what that may result in is paralysis of the hemidiaphragm, and it could, chest x-ray could look like this. Again, if the patient's got relatively healthy pulmonary status, then this is not even going to matter that much or even and be clinically relevant, but may be relevant in your patients with pulmonary disease or other problems. And then the last thing that could potentially happen is Horner syndrome. This is, again, worth discussing. This should be part of your informed consent. It will be transient. It should go away once the block is worn off, but it could scare patients. It could scare you if you're not aware of it. You don't know what to look for. And just for those of you who might not know, this is one of my colleagues. His name is Dr. Horner, so I like to put him in here. But this is what it might look like. So they're going to get ptosis. They'll get the classical triad of ptosis, which is pretty obvious here. If you look closely at their pupils, they'll have meiosis, and they may have anhidrosis, so they'll have dryness. Sometimes they have redness or warmth on this side of the face. Not that common, but worth being aware of, worth educating, worth being part of your informed consent. The first brachial plexus block we're going to talk about is the interscalene block. And just a reminder, this is the region that it covers. And these are some nice diagrams from sonoguide.com, which is a product of ACEP, so it's worth looking at if you want to familiarize yourself. Things to remember about this is also will give you some motor involvement. This is great for the shoulder and the proximal arm. Some of the most common things that we use this for are dislocations, fractures. Maybe you've got an abscess up here on the shoulder or somewhere on the proximal part of the arm. This would be a great block for that. Now, the way you do this, what this is going to look like, so this is somewhere on the lateral neck, kind of the inferior portion of the neck. This is anterior and this is posterior, and these are the scalene muscles. You'll see little parts of the sternocleidomastoid, just kind of a corner of this coming up, but we're kind of posterior to that. So this is the anterior scalene muscle. This is the middle scalene, and right between that is the inner scalene groove, and that's where these trunks of the brachial plexus lie, and we're going to try to bring our needle right in here and just fill up this groove with local anesthetic. So the way that I like to find this is I often just kind of stay low on the neck, and I find the carotid just above the clavicle, and I start to slide posterior until I see the anterior scalene, and then I just do a slight adjustment, fan up or down, until I see those nice little stoplights lined up in the inner scalene groove. And here's our little video of that. If we needed to do the inner scalene block, identify the thyroid and the carotid, slide back, and right there is the inner scalene groove if we need to inject that. And here's just another example, and this we see this is anterior, this is posterior. Here are our trunks of the brachial plexus. So let's pause this a second. And there, it looks different, a little different from patient to patient. This is our inner scalene groove. These are the trunks of the brachial plexus. This is anterior scalene and middle scalene muscle. And you're going to see we're going to bring the needle right down in here from posterior to anterior. We're going to inject right into that inner scalene groove and just fill up that groove with local anesthetic. Next block on our list is going to be the supraclavicular block. This is another brachial plexus block, just slightly distal. Sometimes this is referred to in the anesthesia world as the spinal of the arm, and this gets you kind of distal to the shoulder, but then all the way down, including all of the hand. So this is really nice for kind of forearm things, something in the hand, or maybe the whole hand is involved and you don't want to block each forearm nerve separately. So that's where this could be useful. Some of the concerns here, it's similar to the inner scalene pneumothorax, because you aren't far from the lung. You're right next to an artery. We'll show you that anatomy here in a second. Some advantages of this: at that supraclavicular area, the nerve bundle is all nice and pretty close together, so you can do pretty low volume block and you get nice coverage with this block. And this is kind of my algorithm on how to find it and localize it. We start at the proximal clavicle, we slide a little bit posterior, we use the first rib as a backstop, and then just little slight adjustments with rotation, fanning, to get you kind of a nice image of what that's going to look like. Let's take a quick look at that. So I'm going to show you guys the angle of if we were going to do a supraclavicular nerve block. There's the supraclavicular artery. You can see the nerve bundle around it, and we've adjusted so we can view it sitting right on top of the first rib. So this is where we would inject it if we needed to. And this is just an example. Let's go ahead and pause this for a second. So we're in the supraclavicular space. So this is anterior on the patient's body, and this is posterior. This is the supraclavicular artery. We've kind of lined it up where we see it over top of the first rib. And this is the nerve bundle sitting just posterior to that artery. And then we'll kind of slide forward until the artery's off the edge of our screen. And we're going to bring our needle down to inject around this nerve bundle. So we bring our needle here. We're getting close. We're trying to inject over top of that nerve bundle, and you see that there. Then we're going to back up and then redirect the needle to get underneath that nerve bundle and try to surround that with local anesthetic. And we try to identify, so this is lung sliding and this is the first rib. So we try to line this up so that the first rib acts as a backstop for us. The infraclavicular, and there's a couple different approaches to this we'll look at. The infraclavicular gives you a similar distribution of anesthesia to the supraclavicular. A couple concerns, it's a little steep angle to get the kind of classic way to inject this. Pneumothorax is concerned, there's nearby vasculature just like the others. Again, advantages are that if you do this well, it's a low volume block, it gives you good coverage. Because it's a little bit more distal, there's less likelihood of a Horner syndrome or diaphragmatic paralysis. It's not zero, but the risk is lower. So the way we do this, we identify the subclavian artery just underneath the clavicle. So here we're cross-sectioning that, so their head's up here and their feet are down here. We've identified that subclavian artery, and we bring our needle down, and it's a pretty steep angle, and we're trying to we're just using the artery as our landmark, and we're injecting local anesthetic to kind of undercut that artery. We make kind of the U-shaped local anesthetic distribution underneath the subclavian artery, or you may call this the axillary artery because we can see it under the clavicle. The biggest downside here is this steep angle, which makes it a little bit harder to track your needle, and theoretically at least a little more concern for pneumothorax. Now there is this technique where you come from underneath and posterior under the clavicle. This one takes a little practice, but one of the nice things about this is the needle comes in very parallel with your ultrasound probe or perpendicular to your ultrasound beam, so it makes it easier to see, and you can see how we've identified this here. So this is from the clavicle. We bring it underneath the clavicle, and then we should identify the needle as it emerges from underneath the clavicle, and we just get underneath that axillary artery, and then we inject and fill up that same exact space. But now we don't have to direct that needle vertically, and we should be able to see it more easily. This is definitely one I would practice on our cadaver models a little bit first, but very popular in the regional anesthesia literature. This kind of last brachial plexus block we're going to talk about is in the axillary position. So this is a good one for kind of more distal, kind of elbow down, includes all of the hand. Concerns with this are, you could hit the artery. The nerves are not as together. The nerves are a little more scattered around the artery, so there's a little more variability, which makes the success rates a little bit lower. But some of the advantages are you're away from the chest, so you don't have to worry about pneumothorax. This is distal enough that you no longer have that concern with diaphragmatic paralysis, and you don't have to worry about Horner syndrome. So those are some definite advantages to this one. And kind of my algorithm for finding this and looking at this anatomy is, one, understanding the positioning for the patient. Really, you want to find the artery, and your injection target is really to surround the artery with local anesthetic, and then look in the biceps compartment for the musculocutaneous nerve, because if you need to anesthetize the forearm as well, then you definitely need to block that musculocutaneous nerve also, which is sometimes almost a separate or secondary injection while you're in this area. And we'll take a look at this here. We identify the axillary artery and vein. The vein is compressible, the artery is not. The nerve tissue all wraps around. If we slide out into the biceps muscle a little bit, we can see the musculocutaneous nerve right there. If we want to numb the entire forearm, we've got to inject that as well. The rest of the nerve tissue just wraps around the artery, so the artery is your main target if you're trying to do a axillary nerve block. And then the last blocks we're going to talk about in the forearm are the forearm ultrasound nerve blocks, or sometimes called the fun blocks. And these are the ones that these are some of the first ones I ever tried, and some of the ones that I like to teach to beginners early on. They are, I don't know if they're easier, but they're a little bit lower risk and lower volume. So there's a little more margin for error in these, although still, if you hit the nerve, that can be a problem. Again, important to remember the distribution and understand where your lesion is, your injury, whether it's an infectious process or whatever, where you want to be. And then important to understand the fascial planes, and we'll take a look at those so you know where you want to deposit the local anesthetic. Again, these are pretty low risk, they're pretty easy. Understanding the distribution, even though you may be placing the block pretty high up in the forearm, it's really not going to give you anesthetic until you get to the hand. So if you need anesthetic in a part of the forearm, then that needs to be a more proximal block. First one we'll look at is the median nerve. So my kind of algorithm for just identifying the median nerve is I like to just start in the midline portion of the palmar wrist And then I just slide proximally right in the center of that forearm, pretty much to the distal third roughly, and we'll identify the nerve and the muscle. And we'll take a look at that here. Here's a quick video identifying the median nerve. The median nerve, which I like to find in the wrist. If we come down far enough in the wrist, again, indicators towards the patient's right. This is the scaphoid bone sticking up over here. The pisiform bone sticking up over here. So somewhere right in the center is where the median nerve is, probably right there. But we can't see it super well until we track it proximally. We'll see it dive a little bit lateral, dives down more medial, and it's this little triangle centered with muscles all around it. And we can track it back down to the wrist to confirm what we're looking at. Then the next one we'll do is take a look at how to identify the ulnar nerve. And again, my algorithm for identifying it systematically, I like to have the patient flex their elbow because that gives you a better angle for injection. And then I like to just identify the ulnar artery. Remember that the nerve is on the ulnar side of the ulnar artery, and then follow it until I identify the nerve and then see where the nerve separates from the artery. It's usually in the kind of mid to the proximal third of the forearm. And we'll take a look at that here. Ulnar artery is about the same, or ulnar nerve. So here's the ulnar artery. So we've tracked proximally. We can see the nerve tissue on the ulnar side of the artery. You guys see it? And as we track further proximal, we can watch the nerve separate from the artery. And we could inject it there. Frequently, I'm going to have you come up in this with your dukes up position here, just like you're going to fight me. So now I've switched the orientation, still on the ulnar side over here. There's the nerve, there's the artery. So I can identify the nerve in this orientation. So this would be easier to inject in this hands up position if we needed to. And then the last forearm nerve we'll talk about is the radial nerve. And again, my algorithm for identifying it. So I start pretty distally, identify the radial artery, and then I just follow it up the forearm. Remember, the radial nerve sits on the radial side of the artery, just like the ulnar nerve sits on the ulnar side of the ulnar artery. And then as you work your way up the forearm, the nerve bundle kind of migrates towards the bone. Usually your best target for an injection is somewhere around the elbow. So you're going to go up pretty proximally to identify it. So to find nerves in the forearm, first thing we do is find vessels, and I often start at the wrist to find the vessels first. So you guys can see the radial artery right there. Nerve sits on the radial side of the radial artery, and the ulnar nerve sits on the ulnar side of the ulnar artery. So it's not usually visible distally, but if we start to track it proximal, and if we keep the bone and the artery in view here, as we track our way up the arm, we start to see the nerve tissue organize itself between the artery and the bone a little bit. So we can start to see it right here. You guys see the little honeycomb there. And as we go up a little more proximal, it separates, so the artery dives away. The nerve is over here by the bone. And as we get up even more proximal, nerve tissue is right by the bone. Brachial artery is way over here. So right there, if we wanted to block it, we could block it there. And here's just a nice example of injecting the radial nerve. So we bring the needle in plane needle technique. We want to pop through that little fascial plane to get the local anesthetic underneath the nerve. We'll back up the needle and then redirect it to get on top of the nerve. Here we're still injecting underneath. And then here we've backed up the needle, redirected a little bit to try to get some local anesthetic. We're essentially trying to surround that nerve with local anesthetic, sometimes called the donut sign, when you make a donut of local anesthetic all around the nerve, and that's our goal.